We are going to go ahead and get started this morning, and I am just delighted to welcome you to this 12th annual Joseph W. Howe Oration in Diagnostic Imaging. Our institution is proud to honor the numerous clinical, radiological, and educational contributions inspired by Dr. Howe over the past 65 years. Dr. Kettner, the chair of our radiology department, will introduce our oration speaker. And I am very certain that you will find today's oration interesting, valuable asset to your clinical training. So without further ado, please join me in the celebration of Dr. Joseph W. Howe as we bring Dr. Kettner up.
Well, thank all of you for joining us, students and faculty, and thank Dr. O'Reilly and his administration for their constant support of this celebratory event. So let me begin the introduction of our orator, Dr. Michaelis Monteleone. Notice he carries two credentials as a radiologist, one in medicine and one in chiropractic. But Michael's classmate graduated along with Dr. Gary Gilbert, and those two had the good sense to head off to the Philip Institute of Technology in Melbourne, where they were taught by an icon of the chiropractic radiology profession, Dr. Terry Yoakum, who joins us this morning. So Gary and Michael are toiling under the residency of Dr. Yoakum, and both gain access to the radiology specialty diplomate status of the American Chiropractic Board of Radiology. Michael goes on to practice in Albuquerque, New Mexico. So Michael always had a stride for intellectual activity, and this career was not any different. This activity brought him to wander in another direction, but that direction was the British West Indies. He attended the American University of the Caribbean in Montserrat, received his medical degree in 1996, so he went through the rigor of this institution and now enrolls in another institution, and he's going to talk about those experiences briefly, and obtained surgical internship in 1997 in a major center, the Carilion. I have colleagues in the Carilion, and one in particular, quite talented. He's double boarded in pain medicine and neurology. So they have a concentrated talent in that institution. So Michael goes on to 1998, finishes his residency in diagnostic radiology now, and that's at the Medical College of Virginia, and completes a fellowship in musculoskeletal radiology at the Medical College in Richmond. And now his second diplomate is awarded in the American Board of Radiology. So where's Michael today? Well, he's medical radiologist at the Tidewater, Diagnostic Imaging, and musculoskeletal radiologist at the Centera. This is an enormous complex, and he has in the past served, in fact, as chairman of the Department of Radiology and Nuclear Medicine at Centera Williamsburg Hospital. Now, Logan University, with the Department of Radiology, has now for 12 years declared this oration as a tribute and celebration for a pioneer in the chiropractic profession, Dr. Joseph W. Howe. And each year, orators, and they're listed on your program, on the back side of the program, you can see from subsequent years the privileged speakers that have stood before the Logan University audience. And each year, these orators have provided superlative lectures, topics ranging from chiropractic radiology, education, research, and even healthcare policy. And this was designed to reflect the particular skills that Dr. Joseph Howe contributed to this chiropractic profession. But this year, our speaker, Dr. Michael Monteleone, MD, DC, will explore the topic, which is inherently interdisciplinary and collaborative. and I emphasize the term collaborative. It's a fitting topic because it reflects, once again, the contribution of one of the first and loudest interdisciplinary voices in the chiropractic profession, Dr. Joseph Howe. Please welcome back to Logan Dr. Monteleone to address the 12th annual Joseph W. Howe Oration. Please.
Good morning. How's everybody doing? Hope you're all enjoying your lunches. I want to thank Dr. Kettner for asking me to just do this oration, the 12th annual Howe Oration. It's an honor and a privilege to be asked to do it, and I thank you very much for this honor. It's been a long road for both professions. I mean, there's been talk on each side about what's DCE, DACBR, and MD, DACBR. But first of all, I want to talk more about Dr. Howe. Dr. Howe, as we all know, is an icon in our profession. He's done so much for the profession. It's unbelievable. And I didn't realize, I knew that he did a lot for the profession, but until I listened to his oration that he did a few years ago, and then reading too many articles, that I didn't know the history behind everything that he's done, and it's simply amazing what he's done for chiropractic and chiropractic radiology. He's an instrumental figure in the development of chiropractic radiology, dating back to the 50s. I mean, all you have to do is just talk to him and read articles about him and what he's done for chiropractic and chiropractic radiology until you fully realize what this man has done. Dr. Howe is a pioneer in the development of chiropractic radiology. He was instrumental in the American Chiropractic College of Radiology, setting up residencies. He's been around for a long time, and he's done a great lot of good for the profession in chiropractic radiology. Not only has he done much for the College of Radiology, he's a major influence in radiology residencies. I see Dr. Howe as the trunk of a tree, and from this tree trunk, he has just trained and taught and done research to just many, many people, and this tree trunk has grown into a full-blown, huge oak tree that is just massive. He's done a great deal for radiology residencies. Dr. Howe, again, is a progenitor of chiropractic radiology. There's no doubt about it. He's a man of fortune for this profession. A major figure in the development of chiropractic radiology. It's amazing that he was one of the founders of chiropractic radiology. He spearheaded it. He did tons of research to get it going. He was just a bull to get this done, and he just wanted to get it done, and more importantly, he wanted to do it right, and by God, he did it right. He's had a career that's lasted decades, and he's helped and trained many, many people over those decades. Like I said, this gentleman is an icon, and he's a major influence in radiology. There's no doubt about it. And for that, and when you talk to people, you talk to colleagues, you talk to other chiropractic radiologists and academic people and administrators, there's no doubt that this man, Dr. Howe, is considered to be the godfather of chiropractic radiology, without a doubt. There's no doubt about it. He's done so much for this profession and for radiology. Now, Dr. Howe, like I said before, I see him as a tree trunk in the institution of radiology. He's taught numerous radiologists over the years. Many, many, many. And from there, he's, you know, bloomed out, knows radiologists, taught other radiologists. So he's been a force in radiology for many, many years. And both directly and indirectly. So like I said, he's taught radiologists, who's taught radiologists, who's taught radiologists. And indirectly, he's there for the profession and to answer any questions and to help any way he could over the years. And he's done that. Here's, you know, a couple people that you recognize. You know, Dr. Howe has a direct influence on Dr. Yoakum, which Dr. Yoakum was one of his residents. And, you know, Dr. Howe instilled some good theories, good teaching lessons, good ways to teach, and to this day, it shows that Dr. Howe has inspired Dr. Yoakum. And the same way with Dr. Kettner, since Dr. Kettner has known him all these years, and now when Dr. Howe came here in 2000, he's done the same thing. He's inspired Dr. Kettner and Logan College and the residency. And like I said, the tree trunk is the major part, but it just keeps on going and going for this gentleman. So you can see the tendrils, the branches, the leaves of Dr. Howe just reaching out for everybody. He reached out to Dr. Yoakum, one of his residents. And then from there, of course, we have Dr. Alicia Yoakum, another branch on the tree of chiropractic radiology. So it just continues to grow and grow and grow. And it's a tribute to this gentleman, Dr. Howe. It's just, and the tree, you know what, it's going to keep on growing for everybody. Now, for me directly, it was a direct influence via Dr. Howe. Dr. Howe's, I think, first resident, one of two residents, was Dr. Dance. And I first met Dr. Dance here at Logan, like you all are. He was our instructor in radiology, I think the last 6 months. So after Dr. Dance left, or he stepped aside, and then it was Dr. Andrew Jackson. So, you know, the branches just keep on growing and growing and growing. So these two gentlemen were a direct influence on me wanting to do radiology. And it was a lot of fun doing that. And I talked to both of them, and they said, you enjoy it, so you should do it. But the most profound effect after this, as Dr. Kettner said, is my first radiology professor, Dr. Terry Yoakum. As Norman said earlier, I was one of the lucky 2 out of our class to happen to apply to do a radiology residency with Dr. Yoakum in Melbourne, Australia. I think we started that around February of 2000, or 1980. So Gary and I headed down under, and it was 2 years of fun with Dr. Yoakum, and he's one heck of a teacher, as you all well know, and he knows how to inspire and dig the best out of everybody. And I certainly appreciate that. Like I said, he is my first professor. He'll always be my first professor. And, you know, Dr. Howe is a professor of Dr. Yoakum. So the tree just keeps on going. So I know this is an old picture, but this is the, I just thought this was a great picture that I found. This is in Melbourne, Australia, of Dr. Yoakum's residence. And there were 5 of us. The first one, obviously, everybody knows, Dr. Lindsay Rowe, a dear departed soul, and God rest his soul. He was a very bright individual, very bright individual. He was a star. Then after that, myself, you can barely recognize me, and Dr. Gilbert came in, and we started our residency with Dr. Yoakum. And from there, it was Dr. Tom Molyneux, who is, you know, the head of RMIT in Melbourne right now. So he's at the Royal Melbourne Institute teaching people. And then Dr. Jeff Thompson, who is in TCC. So you can see from Joe Howe to Terry Yoakum to Gary Gilbert to coming here to teaching with Norm, to Jeff Thompson teaching in TCC, and and Tom Molyneux, is teaching in Melbourne, Australia, and even though Dr. Rowe has passed away, his teachings are still with us, and in his book that he has done with Dr. Yoakum. An interesting story. In the last, when Gary and I were at the end of our residency, and we were ready to come to the States and take our boards. And I remember, I don't know why I remember this, but Terry came up to us right before we were supposed to leave, I don't know, a month or two, and said, I just want you guys to know that I made arrangements for you, you two, to stop by LACC to be with Dr. Howe for a few days. And I remember Gary, and we knew why we were going. I mean, it was obvious why we were going, to get some more knowledge and be, kind of tested. So Gary said, oh, good. And I said, uh-huh. And I looked at Gary and I said, you know what? I don't think he's going to take us to Disneyland. And it was a good laugh for both of us, and it was a lot of fun. And we went there, and it was a lot of fun with Dr. Howe. It was great working with him and his residents. And this is a little picture off of in Portugal that I took that was pretty nice. So I guess what brought me to this is MD versus DC radiologist. What actually is the difference? And I think some of this was spurred onto me by a couple DACBRs in Chicago many years ago, 3, 4, 5 years ago. There were 2 DACBRs that were from New Zealand, and we were out one night with Dr. Yoakum and Alicia, and they asked me, well, what's the difference between a DC and an MD radiologist? And I said, well, I guess there's a few differences. It's hard to explain, but there are some differences, and some of them, most of it is the same, but there's a lot of it that's different. So I just wanted to go through the differences to give you an idea, what I've gone through. And what helps me is when I left Australia, I had a private practice of radiology in Albuquerque, New Mexico, and all I did was practice radiology. And I had my own fluoroscopic unit and my own table. So I read x-rays and did my own studies. And I did that for 13 years. So I have somewhat of a unique perspective of both sides of the fence. So for both of us, a DC or an MD, it doesn't make a difference. First, you got to get your degree. I mean, you just have to get your degree. There's no way around it. So we both attained that, so that's not a problem. But I have to say, going through my medical residency, not my medical residency, through medical school, that the training I received here at Logan College in radiology was far superior to the medical training I got in radiology as a medical student. There's no doubt in my mind that when you get out of here, you'll know more musculoskeletal radiology than a MD that's just graduating. And some of that is because the MD is taught that to refer to another specific person, like if you don't know what it is or you want to find out more, send it to a pulmonologist. If you want to find out what radiology study you need, talk to the radiologist. So you're kind of like the doctor's doctor, but there's no doubt in my mind you all are going to be more prepared to do musculoskeletal radiology out of Logan than an MD is out of medical school. So after you get your degrees, you have to apply for radiology residency. For the DACBR, I remember that Gary and I went to many places, Kansas City and a few other places in Chicago, to talk to Mike Beeler and Ray Conley to look at the residencies and apply for them. So the DACBR has to apply for the residency. Now, when I got out of my medical school, I also applied for radiology residency, but for the medical part of it, it's through a match program. It's like, I don't say, okay, I went to MCV. I don't say, I want to go to MCV, so you got to take me. And it doesn't work that way, unfortunately. you pick them, and then they have to pick you, and then it's up to the match the way the computers do it. Like I said, we have to go to the match, and and the dice go where they lie. You just don't know where you're going to end up. At that point, where I'm still trying to go through the match, the MD trying to go through the match, the DC that wants to do a DACBR is probably already accepted to 1 or 2 or maybe more programs. And unfortunately for the MD radiologist, we just have to wait and wait. And for radiology is a 5-year residency. In that 5 years, the first year is your intern year. So I had to do even though it's considered part of radiology residency, I had to do an intern year first. So when I went around the United States applying for a residency and talking to people, not only did I have to talk to the people in radiology, I went to the people in internal medicine or the ED, depending on what I want to do a transition. It's to say, I'm trying to get a radiology residency here, and I need a transition year, a first year here, so this is what I'm doing. And it was fine by them because they knew that you were there only for a year, you weren't taking up their slots, and you were going to be a work dog is what you were going to be. You were just going to do their scut work, which is fine. That's how you learn, and it wasn't too bad. Just to let you know, as far as the medical profession for radiology, in 2018, there were 1,398 applicants for a radiology residency across the United States. That's for the applicants. There was only 965 radiology slots at 178 institutions. So you can see that just because you're applying for the radiology residency doesn't mean you're going to get it. It's up to the match, and you may not get it. It's just, it's the toss of the coin. And if you don't get it, you have to decide what you're going to do. Try again next year, or do something else. And when we do this, you hope and pray that where you've been chosen to do your radiology residency, that you can do your internship, because you really don't want to move to one place for 1 year and then move again to do your radiology residency. It's a big work, but sometimes it works and sometimes it doesn't. And again, that is up to the match too, unfortunately. So you're just like, oh, I hope to get it in the same spot. Unfortunately for me, I didn't. And you just wait for the match day. Everybody just sits out and waits to hear. And you just hope that you get to do the internship where your radiology residency is. For me, I got chosen to do the radiology residency in the Medical College of Virginia. Unfortunately, I didn't get picked to do my internship in Richmond at the MCV. I got picked to do a surgical internship at Roanoke Carilion Hospital. And it was pretty good. I was skeptical about applying to do a surgical internship. Again, they knew that I was only there for a year. So, and when they saw me, I was not your typical, young person coming out of medical school. They knew that I already was a doctor. And, and they all respected that I was a chiropractor and that I was a chiropractor radiologist. And they always addressed me as doctor. They didn't care. They just wanted you to do the work, and that was it. So, but I must say, doing surgery for a year, I was with them 3 or 4 days out of the week in the surgical unit doing surgery. And the other day or two, we were in the clinics. But surgery was a lot of fun. I mean, it was a lot of fun. The only thing I didn't like about it is you had 15 to 18-hour days, and it was just gruesome. It was gruesome. But it was fun doing surgery on people. It was fun. In the radiology program, like I said, it's a 5-year program. And the DACBR program is a 3-year program. And DACBR goes directly to the residency program. So you start from day one, where, like I said earlier, I had to do an internship. And like I said, mine was in surgery. So while the DACBR is already, all right, gun-ho into the radiology residency, I had to wait a year. So the DACBR was already done with a year of radiology residency, and I wasn't even started yet as an MD. And then finally you get to your radiology residency. And the second to the fifth year of radiology residency was very intense. It was a lot of work. And lucky for the DACBR, they get to pick where they want to go, and they chose. Like I was picked, and Gary was picked to go with Dr. Yoakum in Australia. And we said, well, we don't even have to think about this, we're going. So that worked out great for us. So in essence, even though it's a 5-year program, because they say it is a 5-year program, the MD radiologist only does a 4-year program in radiology. And yours, again, is the DACBR is a 3-year program. So it's, pretty similar. It's pretty similar. In the programs, they're, depending on the institution you go to, they could pick 2 radiology residencies, or they can pick up to 20 radiology. A small hospital in Maine may only have room for 2 radiology residents, where MCV, we had room for like 40 to 50 residents. So that was pretty good. So when you do that, you have a lot of residents. So at MCV, when I got into their radiology residency, there was, a lot of radiology residents. And throughout the 4 years, you figure if you're picking 2 to 20 residents a year, you have a lot of radiology residents. So in an MD radiology program, you can have anywhere from 16 to 80 residents in one program, which is a heck of a lot of residents. As far as the DC radiologists, I think what I found through my research, it depends on the institution that they would take 2 to 6 radiology residents. And it depends on the money and how things go. For the MD part of it, when we're chosen to do that residency, no matter if it's family medicine or ED or pediatrics or whatever it is, our salary, if you can call it that, was paid for by the federal government. It wasn't coming out of the hospital. So we were paid every year. But believe me, for the amount of work that we did, it wasn't enough money. It was ridiculous. And it depends on the DC radiology program. You can have anywhere from 6 to 18. But again, that depends on each program. And there's similarities between the MD and the DC programs. We all have to do the straight foundation stuff. The MDs and the DCs do musculoskeletal radiology. It's the same. Ultrasound is incorporated in MSK radiology through the DC program. Both professions do neuroradiology. Both professions do radiology of the thorax. Both professions do radiology of the GI system. Both professions do radiology of the GU system. And unfortunately, for every one of us on both sides of the aisle, we have to do physics. And I think out of everything, I could not like physics. And none of us did, for that matter. It was just very painful. But, you can see the parallels are still there. We're side by side basically doing the same thing. But to go even further, our training is a little bit more involved. After those initial areas, I went ahead and did, as an MD, angiography, interventional angiography. When I'm talking about that, that means I'm going in and doing balloon angioplasty at 2 o'clock in the morning to open up an artery. Or there was an aneurysm in the brain that unfortunately burst. So as the resident at that time, you could go ahead and start the process for the neuroradiologist, the interventional neuroradiologist, to go ahead and do some coil embolization of the MCA aneurysm. So it's it's involved, and at times it gets scary. Then cardiovascular, that's somewhat new. You're doing that through a lot of MRI, cardiovascular work. Nuclear medicine, like I said, when I say nuclear medicine, it's just not bone nuclear medicine. It's brain, it's kidneys, it's everything. And it's on adults versus newborn kids. Breast imaging, we all do a portion of breast imaging, but you have to really like to do breast imaging. It is a lot of fun, but it's not something you'll want to do part-time. It's very litigious, and you learned while you're doing rotations through the residency that you just can't slack off. It's too detailed, and once your eyes are attuned to breast tissue and the tiny microcalcification, you got to stay with it. You can't do it once a week, or you lose it. We do OB/GYN ultrasound, pediatric radiology, and that goes far as soon as they're born to their pediatric person. And our experience and my experience is when you're on call to that point, and you're the person in the hospital responsible for peds, they get a newborn, and they want to know if there's a bleed. So you go up there as the MD or the training radiologist, and it's on your back to tell them if there's a bleed in this just born person. And it gets scary because you are the person, you're the end part. Granted, the attending comes in the next day, but they're relying on you because they need something done now. They can't wait till tomorrow morning. And then the abdominal CT/MR, you all do that too, and through the DC program. Once we got into our more advanced stages where they actually trusted you, there was 3 types of call that I had to do as an MD radiologist. Like starting in the 3rd year and the 4th year, we had ER call where I'm using my experience at MCV. I was the ER call radiologist or radiology resident on call. I was there from 7 p.m. to 7 a.m. 5 days a week. And I was by myself. And anything that came through the ER, that was plain films, CT, MRI, and ultrasound. I had to read. It was my responsibility. And it's, the first time you do it, you get scared to death because I went to MCV as a level 1 trauma center, and we saw everything. I mean, we saw people come in that were drunk and jumping over, fire pits and catching themselves on fire. People that were shot and stabbed, they were brought in by cars by their buddies, opened the door and shoved out, and you had to attend to them. And you're talking about bad stuff where we had to do angiograms to see what was going on. It was a mess. It was a mess. But you get used to it, and actually it was a pretty good training tool. I mean, it really prepared you. And then we went to imaging call. So we're done with the ER call. It's like, thank God, because that was very painful. But imaging call was even worse because you're the resident that is responsible for the entire hospital, and MCV was 12 to 1,500 beds. It's a big hospital. And so you're responsible for reading CTs, MRs, and ultrasounds, and then the interventional study that comes up. So if you had to do it, they called you to do an angiogram. At 2 in the morning, you were doing it. And you were just doing it, or you were doing a lumbar puncture. But any procedure we had to do. And you have to remember, we're still residents in training, but you went through the cycle enough where you knew what you were doing because they wouldn't let you do it if they had any reservations. And we were tested every year. I mean, it was good. Then once you get done with those 2 calls, then you get to the mecca of calls, what we call senior call. So it was in our 4th year where you were in the hospital, all night. But as the senior call back up in the hospital, you were the guy that came to when nobody could do it if they had questions. So, but the thing is, nobody, the ER call and the imaging call, you just never bothered the senior call because it was like one of those taboos. You just don't mess with the senior call guy because they were the 4th year and they were ready to take their boards. But it's the rite of passage, and it's one of those things you just deal with. Norm knows this well. This is up in the Sandia Mountains overlooking Albuquerque, New Mexico. Just not that many years ago, he was running up and down these mountains. Not that many years ago. Okay, our resident work hours, just to give you an idea, they were pretty involved, but I think there's a parallel between both. I mean, we work 7 a.m. to 5 or 6, and so does the DACBR. We did that in Australia with Terry. And then you are in the program, and you work to the section assigned. So, you may be MSK, and then you're going to be neuro here, and it's the same way with, the MD portion of it. You read the studies by yourself. You get them all dictated, and then the attending comes in and makes sure that you're reading them right, and then you sign them off. And it's no different than what Dr. Kettner did yesterday when I was here. It's the same exact thing. There's no difference. We did noon residency lectures, and it's done here. And it's done everywhere in every residency department. So the parallels are there, but there certainly are differences. One of the big differences is when I was a resident, as I just said, and I would say I was in neuroradiology, we were doing procedures. We were doing tunneled catheters. We were doing PICC lines. We were doing, we're putting in tunnel grafts. We were doing declots of that. We were doing, brain angiography. So, and in PEDS, it's different, but you're still doing procedures. It's just not sitting in front of a view box. You're actually, you're on fire when you're doing procedures. You have to be careful. But the attendings are there to make sure that you're not doing any harm. From there, I wanted to go and kind of give the difference between the MD certification and the DC certification. It's kind of basically the same to a degree. The MD certification exam is 3 sections, and so is the DC. The MD first section is pure physics. It was all day physics written questions, and it was just painful. And you have to pass that to even go on to do the second, third section. In the same way with the DACBRs. Your first section is 2 days, and where you did physics, bone and joint, thorax imaging, neuroimaging, abdominal imaging, and you all must pass. The DACBR's got to pass to be able to sit part 2, which is normal. You just got to do that progression. If you don't pass it, you don't do the next section. My section 2, as far as an MD, was a 2-day written exam on everything that you've learned through the residency. So it doesn't make, and this was just written. So they could ask you anything that they wanted. Allergic reactions, what are you going to do? How much are you going to give? What are you going to do if a patient says this? What's your diagnosis? What's your top 3 diagnosis? What's the percentage of enchondromas going malignant? So they could ask you anything, and it was all written. And it wasn't too bad. It was not great, but it wasn't bad. The DACBR Part 2 is comprised in 3 different sections, which is imaging, which they do MSK, neuro, chest, thorax, and abdomen. Now, I'm getting this from the ACCR website, so hopefully that's pretty correct. And then the other part of the section of Part 2 is the report writing, where they have to write reports. And I remember doing this as doing my DACBR. And then the third part of their section 2 is the oral interview, where they look at your reports, they look at your imaging interpretations, and they grill you on the cases that you submit to them. And usually it's easier to make those cases as simple as possible so they can ask you a lot of detail. I learned that the hard way. And so the DACBR is all done, and you pass and you're all set. I have to go on to the MD part of it. I had to go on to do part 3, and part 3 was a oral exam when I had to fly to Louisville, Kentucky for this. Every section was tested. We had 2 or 3 examiners sitting behind us, throwing cases up at us and asking you questions. And this was one-on-one with these attendings. And you know who these guys are because they've written articles, they come and lecture to you, so you're going like, okay, I'm in MSK section. You can't, shine smoke because this is the person that wrote this stuff, and he knows that you're just, just faking it. You just can't do it. But it's a lot of sections, and it's 20 to 30 minutes per section, and they just throw up cases and throw up cases. And it's in all these. It's in angiography, nuclear medicine, GI, GU, peds, thorax, everything that you've been taught over those 4 years, they just grill you on. You just got to do it. And the initial part of it was deadly, but it was fun. The recent changes within the last 5 years, they changed the MD part of it, where now you can take the first part of the exam only after your 3rd year of residency, and it's a written examination. And then you can't take the 4th or the second part of that until 12 months after you're done with your residency. So you're out in practice, practicing with the radiology group before you can even take that. So you have to wait a year after you get out of residency to take that. And where the last section was oral in front of people, which I thought was great because you can actually work your way around it. All this is done on computer now. So the last section, which is done on computer, is all imaging. So you're being tested on images that they put in front of you. So they've changed it. Some people say it's for the good. Some people say it's not for the good. So after we're done with the residency, we're board eligible as an MD to be a radiologist. You're considered to be board eligible. And then after you pass the exam, you're board certified, which is fine. For the DACBR, there's no such designation after you get out of your 3 years. There's no designation that says you're board eligible. And when you take your exam and say, God forbid, you don't make it through, because you got to make it through to be board certified, there's no designation that says you're board eligible. There's no designation at all. And to me, it's like you've gone through the 3 years of residency. I'd like to be recognized as at least board eligible to take my DACBR exam. But that's just me. I think it's something that's earned by the DACBR. But I've been told I've been wrong. I've had the good fortune of spending some time with a medical radiologist in London, so I took some time and did some touristing stuff. The fellowship for the DACBR is in ultrasound and MR, and for the MD, it's almost in everything. If it was for me, 4 years of medical school and then 5 years of radiology residency was enough, I decided to do an extra year and do an MSK fellowship, and that was a lot of fun. But I have to say that my time with Terry helped out tremendously. It was great, let me tell you, because I can sit at the board with great confidence, and I attributed that to that gentleman back there. Recertification is basically the same. For the MD, you have to do 30 CME hours a year, which is kind of goofy because in order to keep my, say, Virginia license, I had to do 30 hours as it is. So, but that's the rules and you play by them. So it's easy to do. I have to recertify on a computer. They give me computer cases, and I have to take this online examination. They call it the OLA. And mine is geared towards MSK, so everything I get is MSK, which is great. And then the bad thing for their recertification for the MD part is you got to do a research. Now, if you're an academic institution, it's great. You got the time. Private practice, you have no time to do research. For the DACBR, from what I read through the ACBR, it's 60 educational credits over a period of 5 years, which is kind of ridiculous because I know you all, the DACBR, does a heck of a lot more than that. But that's what's written down. So how many radiologists are there? MD radiologists, and these are recent figures, there's 34,000 to 40,000 medical radiologists in the United States. And for 2018, there was over 1,300 radiology jobs for radiologists. So that's a lot of jobs for radiologists in 1 year. For the DC, from what I gathered, and some of this information was very hard to get, there's between 250 and 400 DACBRs. And I couldn't lock down a figure from anybody. And then the amount of positions is going to depend if you're going to open up your practice or going into academics, or it just depends how that's going to be. This was in Spain, in Barcelona. The number of studies read, from what I gather, for the DC, it seems to be, the DACBR is a little bit variable, because a lot of, I think from what I understand, a lot of the DACBRs have a mixed radiology practice and clinical practice. I could be wrong, but that's kind of the information I got. And a lot of it is playing films. For me, anyway, as far in my practice, there's a lot of films read. So depending on your size, your institution, you can read from 8,000 to 26,000 studies a year. For 2018, for me, I read over 23,000 radiology studies last year. And 30 to 40% of what I read was plain films. 60 to 70% was imaging, which is ultrasound, MSK, CT, so on and so forth. And that includes the interventional things that you do while you're doing radiology. The esteemed Dr. Kettner at his radiology station is no different than my radiology station in Virginia. We both use the Carl's table. This is a Barco monitor that's pretty big. This white box here is where we dictate our reports. It comes up, we dictate them real time, and so whatever we say comes up on that box, and when we're done reading it, you sign it off and it goes to the doctor immediately. The background on that here is all the radiology studies for that patient, no matter what it is and what the reports are, dating back to your entire time at that facility. And the far left one here is all the clinical information, what their surgeries have been, what the labs are, what their path is. So it helps us get an idea of what we're looking at, because half the time when we get something to read, it's either trauma or pain. It's like, well, that tells us mostly nothing. The daily work schedule is 7-11 in our practice. There's a radiologist there, 7 a.m. to 11 p.m. Saturday and Sunday, there's one lone radiologist in the house that does everything from 7 in the morning to 10 o'clock at night. And the holidays are the same. Now, what I found out in general in my practice when I was in Albuquerque, I was working, between 8 a.m. and 5 p.m. And I never had nights, never had holidays, and never had weekends. So it was a pretty nice schedule. For my work week at my practice, you work from 7 a.m. to 5 p.m., so you do the work. And on any given day when we walk in, there's anywhere between 40 and 60 studies waiting for us, and 30 of them could be MRIs. The call radiologist for us comes in at 3 p.m. and they stay till 11 o'clock at night. And they do they read all the studies and do any procedures that come up. Then after 11 p.m., a reading service takes over and we're able to go home. But if something comes in the middle of the night where you have to drain kidney abscess or an abdominal abscess or do a lumbar puncture, you have to get up at 2, 3, 4 in the morning and come in and do it. Where my schedule as a DACBR was 8 to 5. Yeah, barely worked after 5 o'clock, never worked on weekends, but that depends on your situation too. There's DACBRs that work in conjunction with medical radiologists, and that certainly could be different. Malpractice costs is a big one. From what I gathered from NCMIC, it ranged from $650, which I found hard to believe, to $3,500 a year. The medical radiology malpractice averages between $11,000 and $80,000. The $11,000 is when you first get out and you haven't read any studies, so there's not a whole lot of people to sue you if you miss something. But the more that you're in practice, the higher it gets because the more studies you're involved with. My malpractice for this year is $32,000, just to let you know. It's a vast difference, but there's a reason for that. Both factors, DC, DACBR, misdiagnosis. You think it's enchondroma, it's chondrosarcoma. It doesn't make a difference. It's a misdiagnosis. On the other hand, you just don't even see it and don't mention it. And that's a problem for every one of us. It's quite interesting. You got to see it to diagnose it. To go further, and why my medical practice is $32,000 is because of my procedural complications. I have vascular injuries. When I'm doing biopsies, I've gone through the aorta. And luckily, it didn't cause any problems, but these things happen. You can't read 23,000 studies a year and do procedures and be 100%. Whoever says they don't never cause any harm or miss stuff is wrong. It's just not caught. Vascular, my complication in needle biopsy, when I do it, when I'm biopsying that adrenal lesion, you're going to bleed, you can have an infection, or I can damage it, or you could die. That's just the way it is. You have to tell them this. And then you delay the procedure, or you don't give them enough information to the patient. And then there's not enough communication. I tell you, no matter what profession you're in, talk to the patient. Talk to the patient. Because if you're nice and talk to them and tell them everything and something goes wrong, they're going to be on your side. There's no doubt about it. This is why my malpractice is so high. This is a biopsy I did of this soft tissue nodule. Now, well, obviously we did a CT beforehand and we found this, so now we're doing the biopsy. So the patient is prone. These are windows that we use for biopsy, and the spine and paraspinal muscles. And so I'm biopsying this little soft tissue nodule. So you can see where it's next to the aorta. I can cause a bleed, but I biopsy this lesion, and the temno needle we use is 18 gauge, so it's pretty big. So you got to watch out what you're doing. This ended up being a melanoma, believe it or not. Another case, ultrasound. They did a submandibular biopsy. You have to be careful because you can nick a cutaneous nerve that goes to the lip, and if you do, their lip's going to be numb. And that's a known complication. So I did this biopsy with a long temno needle, and this turned out to be a lymphoma. And these are all biopsy proven. Lung biopsies we all cringe at. Even though I'm the MSK guy, everybody does this stuff. It's the way it is. So here's a mass here in the lung base. So you can see how tenuous it gets. It's near the IVC. It's very deep, and it's near the hemidiaphragm and the pleural space. So you got to be careful. And it's not easy because for lungs, the person doesn't breathe the same when you're putting in a catheter. You can miss easily. Another biopsy. This was another lymph node. This is a case that I read. If you look real close, there's a subdural hematoma right through here. And it's subtle, but it's there. These are things you give these cases to radiologists. And one of the complications, doing a lung biopsy and pneumothorax. It just happens. Another complication, mass in the kidney. You put in your needle, your biopsy, you do another slice when you have a huge hematoma. And you hopefully that the hematoma tamponades so it doesn't kill the kidney by compression, or they have to go in and do a subcapillary drainage of that blood. And it's the same thing, kidney, Post-study, another hematoma. And this is a parotid biopsy I did. You can see how long the Temno needle is. It's a big needle, and it's 18 gauge. It's not small. And this was a Warthin's tumor, but again, going through the parotid gland, the facial nerve goes through it. It's a known complication. If you hit it, facial paralysis, and it does happen. Okay, for radiology, both on both sides, DCMD, it's academics or private practice. You can be solo practice or a group. Most of the MD are group practice. You just can't do it by yourself. And for the DACBR, it's the same thing. Solo, a mixed clinical or DC, DACBR. And usually a group of 2 or greater. And like I think Dr. Jochimson got 3 in his. The MD is usually in a group practice greater than 2. Most group sizes in a radiology function is between 8 and 100 radiologists in a partnership. So we had like 25 in our group, 25 partners. And it varies drastically for the DACBR. Just depends what you want to do and how you want to approach, your practice. Most groups range from 8 to 100. You can be hospital for MDs. You can be owned by the hospital and they pay you a salary, or you can be contracting out to the hospital where they build a technical component, you build a professional. This is my 1-year-old grandson. I was born and raised in St. Louis, went to Logan. So I had to get him a Logan or a Cardinal shirt, but I think I'm going to have to switch this to a Blues shirt. And the payment is basically the same, the technical and professional components. If you're owned by the hospital, they bill for both, and you're a salaried employee, they pay you a stipend. Or you can be a contract radiology and deal with the hospital, and they bill for the technical, we bill for the professional. And it's the same way. It's no different for the DACBR. You do it in your office, or you read, you're going to bill. You can bill for both components, or you bill the referring doctor. Or you can bill for the reading service from the referring physician or the insurance company directly. When I had my practice in Albuquerque, we did a little bit of both. And I'm kind of like winding up here. I know you all have to go, but I wanted to show you some differences here. I got these figures off the internet for the chiropractic college. For cervical spine, 3 views, $61, and so on, 5 views, $66, 7 views, so on and so forth. For the hospital that I'm at, the spine 2 to 5 views was anywhere from $400 to $700. The extremities was $548, chest $504, hip and pelvis $900. Do we get paid, or does the hospital get paid that? No, but they usually get 50%, but 50% of 700 is pretty good, and it's certainly more than 61. And I have issues with how the insurance companies pay for this. Some of our imaging costs: CT head, $2,000, MR head, $5,000, the head neck, $8,000, chest, and so on and so forth. But what I wanted to show you, this is back in March of 2018. This is through the ED. So this patient got a CT or a CTA of the chest, which is a PECT. They got a head CT. They got a VQ scan, which makes no sense because the gold standard is the CTA, the pulmonary embolism CT, and they did a PA of the chest. So just the radiology bill for this patient that walked into the ED was $8,300. That doesn't include the $450 of walking in that you're automatically charged, and you're going to get a bill from everybody else. This is just radiology. The same way with this. And if you look at it's mid-abdominal pain. So this is through the ED. This is what they've done. A CT of the abdomen and pelvis. CT of the head. MRA of the chest, which is basically a PECT. An abdominal ultrasound of the aorta to see if it's ruptured, and then a chest. So when you look at all these fees, just one person within a span of 3 or 4 hours, their bill was over $16,000 just for radiology. I remember as a practitioner arguing with the insurance companies to get paid $100 for a 5U cervical series, but they're going to go and pay 16 grand or 8 grand for this. I thought it was ludicrous. This is the Amalfi Coast in Italy. This is Cinque Terre. The licensure and reading studies, for me, if I'm licensed in Virginia, I can't read a study from North Carolina, Pennsylvania. I have to be licensed in those states to read studies from that states, where that's not the case, from what I understand, except for 3 states where you don't need to have a license in those states to read, which is kind of nice. But I think this is flux, and I think that may be changing. But if I want to read studies for a person in North Carolina, I have to have a North Carolina license, or I'm practicing without a license in that state. So just to summarize it, there is differences. There is a difference. The big difference is the hours that we keep, the malpractice, the inherent issues of hurting the patient. And, you know, obviously you try not to hurt the patient, but that's part of it, unfortunately. And the errors they're not that much. Our group is pretty good. We have a very low problem with, you know, issues after doing biopsies and stuff. But it doesn't make a difference to me what you do, what profession. You all are out there seeing patients, and the best thing for you is to use the people that you have around you. It's good for you to refer to Norm or Terry or anybody, because what you're trying to do, you're getting information from the professional, the field-specific radiologist, to help you, and that in turn helps the patient. And let's face it, we're all here for one reason. It doesn't make a difference. We're here to help the patient, and that's what it's all about. And that's exactly what it is. So you can't have any kind of bias. This last slide is with Dr. Howe and his wife Dee. I mean, like I said, he's been around for many, many years, trained a lot of people. And this gentleman has done a great deal for chiropractic in the field of research, clinical teaching, and radiology. And to imagine what this gentleman, Dr. Joseph Howe, has done for the practice of chiropractic, for the practice of chiropractic radiology, and the training of chiropractor residents is phenomenal, and he's to be applauded and appreciated for his efforts, what he's done over the many years. And he deserves big rounds of applause for what he's done. And we all appreciate that. And